Thank you, Mr. Chairman. Thank you, my dear professors and colleagues. It's a great pleasure for me to present my case and discuss it with you today. My case is titled Acute Vessel Closure, an Important Tool to Use. Our patient is 66-year-old male patient, smoker, with positive family history of ischemic heart disease. He came complaining of typical exertional angina, Canadian class 3, of 6 months duration that was not responding to medical treatment. His ECG showed normal sinus rhythm with some changes in the precordial leads. His echo showed normal LV ejection fraction with moderate mitral regurgitation, no regional motion abnormalities, and he was directed to the cath lab to delineate the coronary anatomy. When we went for the coronary angiography, starting with the right coronary, we found that the right coronary is a huge artery, dominant, giving a BDA that gives retrograde septal collaterals, as we can see in the left-sided picture, to the LED through septal collaterals. We went for diagnostic angio for the left system. We can appreciate that the left main is bifurcating into LED and LCX, and the LCX does not show any significant lesion, but the LED show what we can call total occlusion or subtotal occlusion, involving the ostia of the diagonal branch Medina 111. So we started to bypass our first wire. In these situations, I usually start to negotiate the main vessel and start by wiring the main vessel. But every time we negotiate the LED, the wire was going into the diagonal branch. Okay, let's keep the wire in the diagonal branch, and came with another wire to go into the LED. At this stage, with a lot of trials to engage the LED, the patient, as you see that the flow was compromised, and the patient started to have chest pain on the table. So what are the options that we have now? We can reshape the next wire in order to take double curve, or to do knuckling technique into the diagonal branch and do the reverse wire technique, withdraw the wire until the wire get into the main vessel. But this actually, the reverse wiring technique is demand that the vessel that we will introduce our wire knuckle, it must not have any significant lesion that can accommodate our knuckled wire. But in our situation, the diagonal branch had an ostial severe lesion, and we could not pass our wired knuckle like this. We cannot inflate any balloon at the site of the lesion, as you all know, as this will make our life is more difficult. So the next options that can we introduce here is the dual lumen microcaster. Dual lumen microcaster, as you all see, have the same, almost the same design. It's a type of microcasters that have double lumens. One lumen has a monorail design in which the wire هو بس الصورة اللي أنا عاوز أشاور عليها ورا الكرسي. As you all know that the tip of the microcaster has a monorail exchange design, and the over the wire comes more proximal at this knob. We have two knobs, one at the tip of the microcaster and the other more proximal at the over the wire balloon. We can introduce our dual lumen microcatheter and withdraw it, can rotate it left, right, and can negotiate cautiously and bypass our wire through it into the main vessel. And finally, alhamdulillah, thanks God, we succeeded to cross and bypass our wire into the main vessel, as we can see in this picture. Run through wire. Now we take a test. We take our deep breaths, and we found our wire usually in the true lumen, and our case reverted into a regular case. We did balloon dilatation at first at the site of the occlusion, and we did stenting 3.5 by 48 to cover all the lesion up to the ostia of the LED. and we post dilated our stent by 4O balloon, non-compliant, and do both for the diagonal branch. And this was our final result. I have more cases by the same design, but with different difficulty. For this case, for example, we can see here that we have haziness in the diagonal branch involving the haziness in the LED involving the diagonal branch, and we cannot see a tight lesion. So when I see this picture, I got a picture sort of that we may have a dissection here, spontaneous coronary dissection. So I think also the safest device to use in this situation is to pass a wire into one of the branches and to use this dual lumen microcatheter in order to have a good result. The third case, this was a very difficult situation in which we have very tight lesion involving the mid-LED and the diagonal branch, and also the dual lumen microcatheter succeeded to make our life easy. We can negotiate and we can do a lot of wiring techniques, but the results may be not satisfactory for the patient and for us. So, regarding the dual lumen microcatheters, we have a lot of types of dual microcatheter, and the longest one is the Suzuki one, 145 centimeter, and the lowest profile is the Enhancer RX. This is the lowest profile for this guiding. The tip of the microcatheter have different shapes, maybe an oval and maybe rounded shape. I want to say that all have the same design except the recross microcatheter. The recross microcatheter have two lumens, both of them have over-the-wire design. We have the white port. The white port have two openings here, one on each other of the microcatheter. And the blue one, if we introduce the wire from the blue one, it will come from the tip of the microcatheter. In order to remember in an easy way which is which, the white port starts by W, so it has double openings, while the blue one has only single opening at the tip of the microcatheter. Here in this graph, I'd like to say that all of them are compatible with six French guiding catheters, and they can, but if we want to remove it by the trapping technique, we should use the 7 French guiding catheter, except in the Fine Dew Crusade and in the Enhancer one. They can be done by 6 French by trapping technique. We can use the dual microcatheter in a lot of different situations. The highly angulated angles, which was called the retroflexed branches, as we all face. The reverse wiring technique, also, it's a very good option for that. Parallel wire technique in CTO, and in CTO also an antigrade or retrograde if we have a big side branch at the proximal cap or the distal cap. It can help us a lot to end with a good result. So my take-home message is microcatheter in general, I think, in my opinion, it is the most important breakthrough in coronary interventions, specifically the dual lumen microcatheter, one of the most useful microcatheters that can be used in complex coronary interventions, and it should be available in every cath lab for this difficult situation. And thank you for your attention.